Hi everyone, I'd like to welcome you to the Incorporating the Family Voice into Recovery-Oriented Care webinar. I'm Amy LeBlanc and I'm a manager with the Prevention and Promotion Department at the Mental Health Commission of Canada. And I'm really pleased to introduce you to our speakers and to be hosting today's webinar. But just before we get started, I wanted to go through a couple of housekeeping items. First of all, we're really hoping that this is an interactive webinar, so we invite you to send any questions or comments using the chat feature, which can be found on the right-hand side of your screen. And if you can't see the chat box, then if you look for the icon on the upper right-hand corner of your screen, it says chat. It looks sort of like a bubble. You can click on that, and then a chat window will appear for you on the right-hand side of the PowerPoint slides. And one of the things that we ask is when you're sending questions to the presenters, if you could please use the drop-down menu and select all panelists. That way the questions will go to myself as well as the presenters. And then what we'll do is I'll kind of collect the questions and ask them on your behalf to the presenters. If you wanted to chat with all of the other attendees on the webinar, you can select all attendees, and then your question would go to everyone who's currently signed into the webinar. Again, we're really hoping this webinar is interactive, so we encourage you to submit your questions and comments. As well, to let you know, the webinar is being recorded, and so it's going to be posted on the Mental Health Commission of Canada website in the webinar archive section following the presentation. It generally takes about 2 weeks, and then we'll also be posting the slides from today's webinar in English and French. And then as well, just to let you know, given the fact that we have a large number of you on the webinar today, we've muted all of your phone lines just to eliminate any background noise. I'm pleased to give you a bit of background on the recovery-oriented webinars that we've been hosting. And our webinar series originally started to explore the guidelines for recovery-oriented practice that were released by the Mental Health Commission of Canada in June of 2015. The guidelines were developed with extensive consultation, and what they attempt to do is to take the concept of recovery and provide a comprehensive review of what it means to apply recovery orientation in practice or by an organization. And the guidelines look at 6 important overarching themes, and you can see the 6 themes on the PowerPoint deck right now. So the first 7 webinars in this series looked at in-depth at each of those 6 themes, as well as provided an in-depth introduction. And these webinars have all been archived and are available online on the Commission website. Once we finish those 7 webinars, the way that we've been selecting topics for our current and upcoming webinars is we've been drawing on the feedback and comments that we've received in the post-webinar evaluations. So this will be an evaluation that pops up when you're leaving the webinar or when the webinar is over. And we really encourage you to fill out the evaluations because we do draw on that feedback in the surveys to help us find presenters to talk about the topics that most interest you. As I mentioned earlier, my name is Amy LeBlanc, and I'm the Manager of Prevention and Promotion Initiatives with the Mental Health Commission. And I'm really pleased to be able to introduce our speakers for today's webinar, Incorporating the Family Voice into Recovery-Oriented Care. So first, I'd like to introduce you to Ella Amir. Ella has been the Executive Director of AMI Quebec since 1990, and under her leadership, the organization has become one of the principal resources in Quebec for families struggling to cope with mental illness. She was the chair of the Family Caregivers Advisory Committee for the Mental Health Commission since its inception in 2007 until 2012. And she is now one of the advisory council for the Commission. The Family Caregivers Advisory Committee spearheaded the guidelines for caregiver support, which were launched in 2013. Ella holds a PhD in psychology and applied human sciences from Concordia University and an MBA from McGill University. I'd also like to introduce you to Laurel Lamar. Laurel has worked with the Family Advisory Council since 2006. She's a graduate of Seneca College, where she obtained her certificate as a rehabilitation counselor. Prior to coming to St. Joseph's, she worked at the North Bay Psychiatric Hospital for both hospital and community-based programs. She has a passion for supporting families and sees her role as family liaison as preventative. And she truly believes that when families are educated and supported, they are best able to help their loved ones. And Laurel is joined by 3 members of the Family Advisory Council who will be co-presenting with her, and we're really pleased to have them joining us. Laurel will introduce them shortly. And now I'd like to pass it over to Ella to get us started.
Thank you. Thank you very much, and I'm glad to be here. So the very first comment that I would like to make is that mental illness is a family affair. For the longest time, mental illness was regarded as the predicament of the ill person alone, and families were often perceived as the culprit and were routinely encouraged to stay out. Historically, families mostly fell through the cracks of the system, and if they were not pushed away, they were not provided with any help to carry out their caregiving role. Today, there is a growing recognition that mental illness affects everyone around the ill person, especially the immediate family and closest circle of support. The burden that is often associated with caregiving, especially long-term caregiving, has been found to not only compromise caregivers' capacity to provide proper care, but to also impact their own well-being, and often in a negative way. So if we expect families to exercise their caregiving role effectively and at the same time protect the integrity of their own health, it is important, I believe, to offer them proper support. The second slide that I would like to present is, sorry, I think that I have a little problem here, but I will, right. Whose recovery is it? We are talking about recovery and how families can help, but my question is, whose recovery is it? The role of families could be especially important in facilitating recovery, I believe, and today, when the vision of recovery is gradually becoming mainstream, one can hardly imagine recovery without the participation of the family. Families know their loved ones intimately, they have relationship with them, and they usually care and love them. So I would like to suggest that recovery is not the journey of the ill person alone. Indeed, it is the journey of the entire family. We hope that the ill person can recognize and accept the illness, and despite the symptoms of the illness, would be able to move forward and find meaning and purpose in his life. Similarly, I would like to suggest that the family needs to accept the illness as well and the potential outcomes. Sometimes they have to modify the expectations, and sometimes they even have to challenge their own perceptions. And only then, I believe, they can help effectively with the recovery journey of their ill loved one. So what can a family do to facilitate recovery? As said, in order to be able to facilitate recovery, families themselves need to be supported, properly supported. But this is not evident even for the family themselves. When a loved one is in crisis or living with a serious mental illness, families often don't feel it is right for them to expect help for their own needs. They often seek help only after a long time, when the price they pay for being caregivers is evident. Either their health is suffering or they cannot carry on any longer without help from others. But when the family is ready, it can help the ill person reclaim his personhood. It can help the person relearn to be a person and encourage and motivate the person, and it can focus also on possibilities rather than on deficits. But this is not necessarily evident or easy. The innate tendency of families very often, and not only in the context of mental illness, is often to protect or overprotect, to alleviate the pain by taking over and do what otherwise people would or should do for themselves. So to be able to exercise their caregiving role responsibly and effectively, families need information, education, guidance, and support. They also deserve the same respect, compassion, and accommodation that people with lived experience are gradually receiving. So this is what brings us to the guidelines for caregiver support. And since the recognition that the Family Caregivers Advisory Committee at the Mental Health Commission of Canada recognized of the deficiency in that respect, and realize that if we really want to forward our attempts to support families, we have to make a concerted effort to create some guidelines that will help to do exactly that. And this really what gave birth to the guidelines for caregiver support, that the cover of which you see right now. Now, there is really 3 reasons why we why we encourage the Commission to develop these guidelines. We believed that the guidelines or following the recommendations in the guidelines would certainly benefit the person living with mental health problems and illnesses, because the family will be better equipped to help in the recovery journey. Of course, we believed that following some of these recommendations would help the caregivers to protect, as I said earlier, the integrity of their own welfare. And we believe that if this will help both the person with mental illness and the family, it would ultimately benefit the health and social services system. Again, I'm not going to go into details in that respect, but I think that it's quite clear that if families will be well supported, they may require less services for themselves. So these guidelines for caregiver support basically present a vision and a blueprint for comprehensive, principle-based, evidence-informed system of care that supports family caregivers to provide the best possible care to adults living with mental illness while maintaining their own well-being. The Family Caregivers Advisory Committee with the Commission has worked intensively and extensively into putting together this document, which I hope covers all the important aspects that, if they are being followed up, would make this possible. These guidelines were targeting specifically system planners, policymakers, and service providers, of course with the intention of benefiting the ill person, the family, but we believed that if a change has to come, it is likely to come from people who have some power in making decisions. So these are, as I said, the system planners, policymakers, and service providers. We hope that the guidelines provide ample information for planning and for implementing different recommendations, and of course evaluating mental health care services. This doesn't necessarily mean that you have to start from scratch, but you can pick up any recommendation after you have evaluated the state of services for families in your own organization, and apply what suits you. It recognizes and addresses the unique and urgent needs of family caregivers that until very recently have not been addressed properly. The guidelines include 41 recommendations in 5 categories. Again, we try to make it very accessible by dividing it up into different categories, so people in different, or stakeholders in different domains could pick and choose the recommendations that are relevant for them. So as you see here, we are talking about integrating family support into mental health services. So this, for example, in the hospital or in other establishments where people with mental illness find themselves, and of course, families as well. So here, for example, we have recommendations to provide proper information, to make referrals to family associations, for example, and coordinating continuity of care. Other recommendations are referring to the training and support for mental health service providers, because we know from experience that many of professionals in different domains are not necessarily trained to offer the proper support and guidance for family caregivers. So they themselves, we believe, deserve to be properly supported. And then there is another category of government and policy, for example, financial consideration or health and safety policies that are under the jurisdiction of policies and government responsibility. There is also intersectorial partnerships. We know that when we talk about mental illness, it's not just the mental health care system alone. We are talking about education, about institution and community. We are really talking about collaborations and partnerships between several sectors. And of course, we are talking about public awareness. It is really important in our perception to increase public awareness that could be in any other place where people with mental illness and or their families access, like general practitioners' offices, like schools, and anywhere else in the community. So this is really just, again, just few words about our hope that these guidelines recommendations will be taken up by as many stakeholders as possible in order to change the culture of family inclusion. I should say also that even though the guidelines have targeted, as I said, decision makers and service providers, it is quite clear to us that the drivers of these guideline recommendations must be family caregivers. We will talk a little bit about it later, but I believe that in most cases, if it wouldn't be family caregivers who are going to drive this movement, we would probably have to wait much longer before some of these recommendations will be implemented. So I would stop here, and I'm sure that I will be back to entertain some questions later.
Thanks, Ella, very much. Now, Laurel, I'm going to turn it over to you and the Family Advisory Council to walk through your presentation.
Thank you.
Hi, Laurel, are you there?
Yes, I am here. I'm just trying to see where my presentation is.
Oh, we can flip the slides forward from our end if that would help.
Okay. Okay, so there we go. So thank you for the opportunity to speak with you, and I'd like to introduce members of the Family Advisory Council that are here with me today to participate in this webinar. There is Sandy Sorrenzia, who is one of the originator of the Family Council for Parkwood Institute of Mental Health Care, London. We have Carol Riddell-Elson, who is also a long-standing member of the Family Council. And with us is Kelly Kitely, who is a social worker in a program at our Southwest Center for Forensic, and she has been supporting the Family Council for many years. So what I will do is I will turn it over to Sandy Sorrenzia, who will lead the first part.
Hi, thank you, Laurel. I'm going to give you a brief history of the Family Advisory Council at Parkwood Institute for Mental Health. The concept of a Family Advisory Council was first introduced into London and St. Thomas psychiatric hospitals in 1997 by two social workers and an occupational therapist who issued a mass invitation to family members of the patients at both sites. From a room full of people, a chairperson and a volunteer committee were selected to develop terms of reference and a strategic plan. The committee evolved into a council whose primary goals then and now was to support, educate, and empower families so they could become full partners in the care of their ill family members. The families wanted to work with clinicians to ensure that their loved ones would receive the care and services they needed and deserved while maintaining their own well-being, which was often very fragile. Around 1995, we submitted a proposal to the Thames Valley District Health Council for funding for a family project, which resulted in our hiring a family member part-time who, among other undertakings, developed and taught a 12-week family education course, which still continues. In 2003, we obtained funding from the Tillman Foundation of St. Joseph's Hospital to establish a family resource center at the London site, staffed by volunteers and housing perhaps the best collection of books and other resources on mental illness in the London vicinity. By 2006, the program was fully funded by the hospital, and a paid staff, Laurel Lamar, was hired to coordinate the various programs that had been established and to expand our services. At present, the Council has 20 to 25 family members, as well as Laurel, a social worker, a vocational therapist, and an administrator. We meet monthly, participate in numerous committees, focus groups, and projects across St. Joseph's, interact with the hospital's patient council, and feel that we have a voice that is heard and respected. The partnership between the hospital and the council has been essential for the council's success. Although most of the ideas for programs have come from family members, the hospital has supported our endeavors by providing staff, space, and finances when needed. We are proud that some of our outreach activities have been adopted by other organizations, which you will hear about later. And now Carol Riddell Ellison, who was, as Laurel said, here from the beginning of the family resource opening and has been a leader in many of our endeavors, will highlight some of our key accomplishments.
Thank you, Sandy, and good afternoon, everyone. It has been 14 years since the Family Resource Center opened. In the beginning, the Resource Center was operated solely by family volunteers. It became apparent through the many phone calls we fielded that families needed more support than they were receiving. By making use of family members with specific skills on our council, we added 3 programs to the existing educational program. These were one-to-one counseling, couples mentoring, and a family support group, all of which were received enthusiastically. As Sandy mentioned, a key accomplishment of 2006 was the hiring of our dedicated staff person, Laurel Lamar. This has enabled us to provide much more than we could previously. The family education course continues to be offered twice yearly, and ongoing family support is available through both staff and volunteers. Information about what is available to families is provided to all new staff joining the mental health care program at St. Joseph's. A regular newsletter focused on families is distributed regularly electronically. We have an active web page on the St. Joseph's website, and a patient family handbook is available. The Family Inclusion Project booklet, created by staff and family members of the Council, provides staff with valuable information about the role of families in the recovery journey of their loved ones. Monthly Family Advisory Council meetings allow new issues and concerns to be raised and addressed on an ongoing basis. Excuse me. In addition to what families do, we are called upon to offer advice and participate in mental health-related issues. This has included committees on seclusion and restraint, zero suicide, research, as well as participation on the Quality Committee of the Board of St. Joseph's Healthcare, to name a few. In 2016, we created a Family Charter of Rights. Our charter is being used as a model by a number of other family councils across the province. From a provincial perspective, we are founding members of OFCAN, the Ontario Family Caregivers Advisory Network. And most recently, we contributed to St. Joseph's being the recipient of a significant project grant from the Change Foundation called Changing Care, CARE standing for Communication, Assessment, Recognition, and Education. This project will use the lessons learned from our experience of engaging and working with families by applying them to other program areas of St. Joseph's. From these highlights which I have shared, it's safe to say that our Family Council has been a dedicated and active force for change at St. Joseph's Mental Health Care London. It is now 2017, and our voices are not only heard, but heeded. And now I would like to turn it over to Laurel and Kelly, who are going to talk about our partnerships and our collaborations.
Thank you, Carol. Okay. So I will address this particular slide, which is quite busy, but I was just wanting to provide an overview of a lot of partnerships and collaborations that we have had throughout the years. So without collaboration and partnership, we would not be here today participating in this webinar. We wish to extend our thanks and appreciation to certain individuals and departments who have assisted us, namely the Leadership Group of Parkwood Institute Mental Health Care, the Communication Department, Tamara Mason for all her help with the technical equipment, which we are so grateful for, Kathy White with Organizational Development and Learning Services, and my colleague Rachel Hudson with the Patients Council for their support with organizing the viewing of the event here. I have the privilege of speaking about partnership and collaboration, two ingredients that have been essential in the Family Advisory Council's journey. As you can see from the slide, we have partnered and collaborated with many groups and agencies. We have and continue to partner with the immediate mental health care programs of Parkwood Institute for Mental Health Care, mental health and addiction community agencies, other hospitals, provincial body of Family Advisory Council, Health Quality Ontario, and the Southwest LHIN, to name a few. And let's not forget the Mental Health Commission of Canada. The journey in building these relationships is continuous with mutual goals of the best possible care for our loved ones and to assist and support families who are at times holding the hope for their loved ones. The family education course that is offered twice per year is a great example of the partnerships with a variety of groups. There are families, people with lived experience, and professionals who all come together to provide mental health education for families. We also boast many partnerships with the Patient Council. And for example, we have advocated that a wall be installed, a privacy wall be installed in the health services area of our facility to separate the waiting area from the ECT recovery room. There was actually a direct view from the waiting room into the recovery room. So we're glad to say that this has been installed. We also advocated for a more welcoming atmosphere and privacy for both patients and family in our front lobby. Changes have occurred, and it is now much more welcoming, and people's privacy is being respected. There was a lot of advocacy from our Family Council and Patient Council that went into this work as well. We also worked very well with the Patient Council to establish two drop-in centers for both London site and Southwest Centre site, and this is a partnership with Patient Council, Family Council, and the volunteer services. Currently, we are working in partnership with Canadian Mental Health Association London Middlesex and Access from Chatham-Kent to hold training for families who have a loved one with emotional dysregulation. We're actually collectively looking at partnering to host some training for families from a program in Toronto who offers this. So this would be a great opportunity for all areas that are working with family to come together and offer this. We also partnered with frontline clinicians and community agencies and hosted our first Leisure Expo last October. We wanted to promote the leisure resources available in the community for inpatients and outpatients, as well as their families and support. We're happy to say that this was an excellent turnout. So we're planning more of these expo-style activities. The Family Advisory Council representatives on various committees, Carol named quite a few of these. So we have representation at the Quality and Recovery Advisory Council, Zero Suicide, Safe Wards, the Research Committee. We also had a lot of input into a current feasibility study that is being done for our organization along with our partner, the other hospital, London Health Science Centre. These are only a few examples provided to illustrate the importance of partnership and collaboration. Without these strong linkages, the Family Advisory Council would not be able to accomplish many of their goals. So now I'm going to turn it over to Kelly Kiteley, who will lead us in our last segment.
Good afternoon, everyone. I'm talking about this last section on behalf of Kathy Gauthier, who could not be here today. I just want to let you know that the path for the future looks bright for the Family Advisory Council and caregivers of those who suffer with mental illness here in London, Ontario. There has been strong advocacy for meaningful activities, and this is based on the importance of our patients receiving opportunities to experience success, to have increase in self-esteem, and to have productive use of their time while in hospital. There has been some advocacy for consistency to happen across St. Joseph's Hospital for employees to look at families as important and needing education, and thus have the Family Resource Center and the Patient and Family Handbook is being advocated to be part of the inpatient orientation package when a patient comes into hospital. Further, there has been a note of the importance for housing for the mentally ill, the provision of supervised 24/7 housing to help with medication adherence and support, and to improve quality of life for those who require that degree of support is seen as crucial going forward. Family Inclusive project occurred, and we're hoping that the patient and family partnership will continue and that there'll be a strong framework that people will work from that value the voice of the family, that understands the family's need for hope, and to affirm the family's role in recovery, and understanding the importance of collaboration and to be seen as partners in care. Further, in terms of ongoing building of partnerships, our Family Advisory Council has been asked to be on numerous committee work and to be a part of the research table in mental health, so as seen as having a voice on those committees. There has been some challenges in terms of confidentiality and privacy laws, in terms of patients not willing to give consent for family members, realizing that family members can contact the team and provide information. However, sometimes that even becomes a barrier when service providers may not wish to receive that information from families. So this is also another area to be looked at in the future as a future path of advocacy and looking at those barriers. There's also been great work in regard to a patient survey and understanding the patient experience. And there's now some advocacy happening in terms of having family surveys being conducted, which is a provincial hope that will look at the family's lived experience and to provide feedback to caregivers on the care and service delivery provided to their loved one. So in keeping with time, I'll stop there and would be happy to entertain any questions.
Thank you very much. I appreciate both Ella, Laurel, and the Family Advisor Council members for your time to provide an overview of the work that you've done to date. We have some time now that we're going to be able to sort of dig into some deeper questions with all of you to get a better sense of some of your experiences and some of your recommendations and thoughts on how organizations and providers can best incorporate the voices of family members. So I'm going to encourage all of the other participants who are on the webinars to continue to send in some questions, and you can, again, remind you to post them to all panelists, and we will write them down and I will post them on your behalf. But maybe just to start it off, I'll start a question to Laurel and the Family Advisory Council members, and that's really to sort of dig into your experiences as caregivers and how working on the Family Advisory Council, what that experience has been like for you, and if it's changed your experience as a caregiver.
Well, certainly, because once you become involved with the Family Advisory Council and you begin to dig into some of the jobs that need to be done that actually make a difference in the system, it's very encouraging and very empowering. And I think we learn to communicate in a very different way with the professionals. And we recognize by being surrounded by other council members that we're not alone. We recognize that we need relief from stress, and we collaborate and talk about how things are going with each other. And so I think it's been a very rich experience for me personally to be a member of the Family Advisory Council, and maybe Sandy would have something to say about that as well.
I would say when you're establishing a family council that you have to realize that there might be periods of discouragement that you go through regarding the council, because there were times when we really weren't sure we were making a difference. But we picked each other up, and the staff at the hospital encouraged us, and we now feel that we really have made an inroad and are quite comfortable with what's happening. We're pretty tenacious and resilient group, and we're creative, and we do a lot of problem solving. We're focused, we're hardworking, and I think it's been, as Carol said, you know, the concept of you are not alone. There are other people there with you.
I'd just like to add to that. I was speaking to another family council before coming in, and some of what she shared was that exactly that, the companionship of being with people who got it, who knew exactly what you were going through, and as well the education and information that was learned was very, very important, and also gaining more confidence in herself with her abilities to advocate and to ask for the services. So I just wanted to add to that as well.
Great, thank you. You mentioned a little bit about the fact that being part of this group has allowed you to almost do some self-care and to have a group of people that you can rely on. Do you have any suggestions to other caregivers on how they can balance that caring for their loved one while also taking care of themselves?
I'm chuckling because there was a time in our lives where we said all we did was pray and cry. And we were in a particularly bad situation with our son, and we had planned this week-long canoe trip in Algonquin Park, and we just knew we could not do that, even though we very much needed to do that for our own mental health and our own good health. And a good friend of ours stepped forward and said, you need to go. I will go to the hospital during the week and make sure your son is all right, and you must just go off and forget about it if you can. And I thought that was the greatest gift I have ever received in my life. And it made a huge difference. We were ready to pick up the fight and continue on after that week. And so I always recommend to people that they find a good friend or a family member who will give them some respite from time to time. It doesn't have to be a week. Sometimes a day will do it. It'll make a difference, or a couple of hours, but try to partner with someone or a group of people that might give you a chance for respite.
Sometimes you can't find a balance, especially early in serious mental illness. But you have to realize that time will pass and not feel guilty. I know for the first 6 years that my son was ill, I didn't want to go any place on vacation because I couldn't imagine going someplace and telling him that I was going to have fun and he was going to be in the hospital. But you start to realize that that's not helping the ill person, and it's certainly not helping you, that if you want to have the strength and the stamina to deal with the illness, you have to be healthy yourself. And so taking care of pleasurable activities without feeling guilt is really important.
Thanks very much. We've been getting in a number of questions from the webinar participants that are really kind of starting to ask about or get at kind of how do you balance the, as a family member, how do you balance or offer care to your loved ones? So Ella, I think I'll pose this one to you. And there was a question about how, for people who are caring for an elderly patient or a parent and they have no other supports, then how can it then be a family affair?
Well, you know, it's a family affair whether you want it or not. The question is if the family is in the position to seek help, and I think that this is exactly what we try to encourage families. Not every family feels that it deserves to be helped, or not every family even feels that it can access help. But I think that this is really the most important message in my view. I think that families have to recognize that when they have someone with mental illness in the family, he has his needs, but it doesn't really suggest that they don't have their needs also. You know, very often families become entirely immersed in their caregiving role to the extent that they really don't think about, you know, their life is totally consumed by their caregiving role, which is very often not even good for the relative themselves, and certainly not good for themselves. So I think that the main thing is really to recognize that your life is not over because you have someone in the family with mental illness, and you continue to deserve any kind of support and help for yourself if you really want to help best to your relative. So this is really, you know, the principal message that I would suggest.
Great, thank you. And maybe, I don't know, Ella, if you wanted to comment on this next question, and then we can see if Laurel and the group there has any thoughts. But how do you handle circumstances when the person living with a mental illness doesn't want their family member involved in their care?
Well, again, you know, you are asking a very broad question, and I think that every case has to be studied in its own, you know, I think that every case may be quite different from another. If the person lives with the family, for example, I think that it is important to, you know, recognize that the family has a role, probably active role, in trying to help this person. And I think that, you know, one of the things that we are doing here at AMI Quebec is working with families on how best to interact with the person who is ill, how to communicate with the person who is ill. So I think that it really depends on the circumstances. I have to say that one of the things that we stress in recent years is really to try to look at opportunities rather than at problems. I think that we all have a tendency, which is, you know, I think that probably ingrained in our education or in our, you know, culture, to try to solve problems. And I think that very often what happens in mental illness, the person with mental illness, first of all, in some cases, doesn't even think that he has an illness. So, you know, of course, he is not really willing to, you know, to listen to any advice or to seek any help. But I think that if you start communicating with someone with mental illness about how he would like to live his life, you know, how best we can help you to accomplish or to achieve something that you would like to, our experience is that there is an opening for a conversation that could be that much more effective than if you are trying to tell your relative, oh, you have to take medication or you have to go to the doctor and so on and so forth. So it's really, you know, to some extent it's a paradigm shift, but I think that it's really important, especially if you try some strategies that have not been working for a long time, you may like to challenge yourself and maybe try something else.
Kelly Tightly calling in. The other part I'd like just to add is that I think service providers and treaters need to make a commitment, make a very clear commitment to family members that you will continue the dialogue with the patient about consent, that we understand that when people are admitted, they may be very ill in the throes of illness, and through their road to recovery, they may change their mind, they may have a different view about their family system or have better appreciation of their role. And so I think we need to rest assured that that dialogue will continue. And I think that when family members call, that we need to extend our empathy, our understanding, our appreciation about their situation and the struggle that they have and their wish to have the ability to understand what's happening with their loved one. I think that's what's important, and to offer them the support that they require and to direct them to areas and to service providers in the community that may be of assistance through that difficult time when no consent is offered.
They also need to, families also need to know that legally they're able to give information to clinicians. They may not be able to receive it under the confidentiality laws, but they are able to give it. And so clinicians need to know that too.
And I wanted to add, when you think about families, it's not just a mother, father, and the ill person. In my case, I have 5 children, and so it is indeed a family affair, and children react differently one to another. And so parents and healthcare providers have to help those families come to terms and have to help families learn how to talk to each other and reconfigure after the illness hits. It's not going to go away. This is something that we're going to carry forward, and we all have to make an adjustment, and I think that's important to realize.
Great. Thanks very much. That you're sort of in those answers, you touched on a couple of the questions, other questions that had come in. For example, there had been a question about whether or not families are able to provide information to their service provider, and it sounds like from your response that that is indeed something that you can do. And another question that came in was, how can families really self-advocate? And it sounds like in your answers that there's a few pieces about kind of supporting one another, sharing information with service providers, taking care of yourselves. So I don't know if there's other ones that you'd want to, any other advice you'd want to give on how families can self-advocate?
I think it's really important that families realize that they are not the cause of the illness. I became involved in the mental health field in the time when I was being told as a mother it was my fault, and the best treatment would be for my son not to see me for a couple of years. Fortunately, for most people, that has changed, but there are still people out there, friends, families, perhaps some clinicians, people themselves who feel that it's their fault that their family member is ill. And it's really important to know that you're not, so that you feel comfortable advocating and don't try to pull away.
If I may add, I think that it's really important to recognize that to self-advocate can be a challenge. You know, people come from different walks of life with more or less confidence in what they can do, especially when they speak with professionals who have the authority in their field. It's not easy to self-advocate. My recommendation would be join a family association. I think that it's much easier, and I think that's what my colleagues here are attesting to, is exactly to that. You know, when you are not alone, when you work in a team where other people share similar experiences, it is an extremely empowering experience. And I think that it's much easier to work that way. I think that it's also important, well, you know, you do say that families have to recognize that they are not the cause of mental illness, but we know that, you know, if we're parents, maybe especially if we're mothers, when something goes wrong with a child, immediately we wonder, what have we done wrong? So I think that even though we are working very hard to destigmatize and to, you know, to impress on families that this is really not their fault, you know, there is an innate tendency, I think, to take some responsibility for that, and this can be a paralyzing experience. So this is even another reason why, if you get together with like-minded, with people who can support you on your journey, I think that it's much easier to recognize that this is indeed not your fault.
Just a kind of a follow-up question to that, which is one of the questions is, so as family members meet together and meet as groups, have you ever come across situations, or have you ever thought about the prejudice or potentially some of the discriminating or stigmatizing beliefs that family members themselves may be holding regarding their loved ones? Is that anything that you've come across?
We do, absolutely. I think that, you know, it is difficult to be sensitive 100% of the time and compassionate 100% of the time. And I think that we are all human beings, and, you know, with our weaknesses and with our strengths. And absolutely, I think that there is, you know, sometimes a message that society gives us and we internalize. And at the same time, you see that this self-stigmatizing is happening with people with mental illness themselves. So I think that this is, again, this is another reason in defense of family associations, which I believe all, like, you know, family councils like in St. Joseph. I think that this is exactly the reason why families do have to get together in order to, you know, to let go of these notions and try to do their best to help themselves and to help their loved ones.
Sure. This is Carol speaking. When you talk about the ill person self-stigmatizing, I think that can be true in many cases. Our experience was that the first time we took our son to a family gathering, he was still in the hospital, but he had a day pass. He said, "Do you think they're all going to be angry and upset with me because I'm sick?" And it had never occurred to us that he would even be entertaining any of these kinds of feelings, but clearly he was really worried about that.
Look, I think that, you know, as long as we're trying to promote excellence and, you know, achievement and accomplishment and everything of this kind, people who are falling outside of the mainstream may have a hard time. So I think that this really behooves on society at large and our communities to be more inclusive and to accept people as they are. I think that only then it will be easier for people to feel that it's okay, you know, to have whatever, you know, issues you may be dealing with. I think that very often we are, you know, the baggage that we are carrying is a secret, which makes it that much more difficult to deal with that. But if we'll be more open and more tolerant and more accepting that, you know, everybody has his own issues, it may be easier for everybody involved.
It's Kelly. I also think that it's important that as caregivers and care providers and treaters is that we need to stem the tide of stigmatization of families and to embrace them and to recognize them as the witnesses of their loved one's life, that have valuable knowledge, that have, you know, important experience that they wish to share, and that it's, you know, that it's sort of our torch that maybe can help what you're speaking about being inclusive and stemming the tide of stigma and you know, and understanding the lived experience and the value of family input.
I think one of the best things as family members we can do is to acknowledge that our family member is ill, and to inform and educate people about it, because when they see that the child or whatever, mother, father, sister, brother, of somebody that they know and somebody that seems to be quite like them can be ill, they start to be much more accepting of it. So our advocating just by providing information, I think, is really helpful.
Thanks again for your comments. I'm going to we've been getting a lot of questions in from the audience, which is excellent. So I'm trying to get to as many as we can in the time that we have. I'm going to switch streams just a little bit right now because we've been getting a number of questions that are kind of getting at how have you done the work that you've been doing with the Family Council. So to Laurel, how do you recruit your family members to the council?
So currently, when family member, because I am a paid and regular staff and I'm totally dedicated to supporting the Family Council, I am actually probably the first person that family members would come into contact if they come into our Family Resource Center. And if I am meeting with someone who expresses an interest in advocacy and they are ready, which is very, very important as well, because if a person is in a state of crisis, they are not ready for advocacy piece. And the Family Council also really recognizes that. And then what I would do is put them into contact with our co-chairs, so that the co-chairs can actually speak with the interested family member and see if it would be a good fit. The other area, or the other, we've seen family members who will also inform the council that they have someone who's interested, and then we go through that process as well.
And additionally, social workers give out the Family Resource Center information, and there's a contact number, and it talks about the Family Advisory Council there as well. So that's another way that people know about the Family Advisory Council.
Mm-hmm. And have you had any feedback from family members about how well they feel they're supported by staff, such as through satisfaction surveys? Is that something that's done at St. Joseph's?
We currently do have a family survey that goes out every year. However, the organization is actually looking at perhaps another tool, but there's also the provincial body of Family Council is also looking to see if there could be a standardized tool. OFCAN is looking at that. But there is a survey that asks numerous questions, and one of the questions that really prompted us to really work on our family inclusion project was when we asked on our survey, are you aware of the services available for families? And we had listed the Family Resource Center, the Family Education Course, and the Family Support Groups, and the numbers were very, very low. And really, with the assistance of a social worker at that time and my director, we looked at a family inclusion and how could we promote it. And so right now, we're still at the table really trying to promote family inclusion within the organization. And just this week, I think we've heard that they have taken our recommendations, and we will be hearing from them to see if they could adopt some of those recommendations and suggestions.
Great, thank you. And we have a question about, do you ever have pharmacists speak at your family meetings? From Wendy, in her experience, it can be really helpful for families to be able to connect to pharmacies directly.
Yes, we had somebody from the pharmacy speak 2 meetings ago, actually. We have people from all over the hospital speak. We usually have 1 or 2 presenters at every one of our meetings. We had one talking about the ACT teams last week, and what's the other one?
The patient partnership framework that we're working on. So we do have that. And as well, we also have a pharmacist who comes and speaks to the families who are enrolled in the family education course. So every year we have a presentation.
So we address issues of finances, of legality, of medication, of symptomology, of how to talk to professionals, questions to ask, all different aspects of
things to do and not do in a family meeting.
And I think with the Family Advisory Council is that there's guest speakers that come to provide the Family Advisory Council information about what's happening in the hospital. So it's a more of a collaborative effort of keeping the Family Advisory Council in the know about special projects, new programs, their goals, what they're working on, the strategic priorities. So that's also happening.
We also have people who will come to the Family Advisory Council looking for feedback. It could be regarding a policy that's being reviewed. It could be in regards to guidelines that they want to establish. But feedback is always sought before implementing anything as well.
I think it's important, too, to recognize, this is Carol speaking, that we have always been welcome to sit on committees. Members of the Family Advisory Council have always been welcome to sit on committees and have our input respected. What our big thrust has been having the institution, the organization, recognize family members as part of the treatment team. And this new initiative that St. Joseph's is about to launch with the money from the Change Foundation is going to focus on that. They're going to actually see families as part of the treatment team, not only in mental health, but across the hospital. And so I think that is a huge gain as far as we're concerned.
You know, the Southwest LHIN is engaged in a patient and family engagement project, and I've attended some of their meetings, and I really feel quite comfortably that we at St. Joseph's are leaders in this kind of partnership. And, you know, hopefully with the ministry and the LHIN getting involved in it, it will be promoted in other areas.
Great, thank you very much. We actually, at the Commission, got one question, and that was if the Commission has a Family Advisory Council. So I'll just quickly answer that and then get back to asking questions of our presenters. So the Mental Health Commission, we had a Family Advisory Committee, and that was something that Ella was involved in, and they developed the Family Caregiver Guidelines. And that committee ended in, I believe it was around 2012. And since then, what we've tried to do with the Commission is on across our projects, when we do work and we have committees or advisory groups, we try to invite people who have lived experience of mental health issues, and we always try to balance with both individuals who have personal lived experience as well as family members. So we try to ensure as much as possible we have the family voice included. And I will say when we developed the recovery guidelines, that family voices were included in that process and were engaged. And maybe I'll use that as a bit of a segue to you, Ella. And I was wondering, you spoke very briefly about the 41 recommendations that were included in the guidelines. And I was wondering if you have any thoughts on, have those recommendations been implemented? If they have, how has there been any successes, or are there any challenges with moving forward with that?
Well, you know, I can speak from my experience here in Montreal, but, you know, I would like to hope that there are, you know, some of the recommendations have been implemented or in the work in many other provinces. But, I have to say, first of all, something a little bit more general. As you mentioned, the Family Caregivers Advisory Committee has been very active with the Commission for the first 5 years, like 7 other advisory committees. But I have to say that even though I think that from the very first days that the Commission was created, there was the wisdom to include Family Caregivers Advisory Committee. But, I have to say that it was a journey to feel actually included in the psyche, even of the Commission. And I say that, first of all, I have to say that, I give credit to the Commission for recognizing it. It has taken some time, but I see that recognize it to the extent that families are involved now in all aspects of the Commission's work. But I'm saying it because I think that it's not evident that family caregivers are included everywhere. I think that St. Joseph or the Family Council at St. Joseph, I think that it's pretty remarkable, I have to say, the relationship that you have managed to create between the Family Council and the Council and the hospital, and probably the proximity of you to the hospital, or you are probably in the hospital, probably allows you to impact change and to have influence in a way that may be more difficult when family association is located in the community, for example. AMI Quebec, which is my organization, is marking this year its 40th anniversary, and we are working closely with hospitals, with community organizations, with clinics in the community. But it's not easy. It's not easy, and it cannot be taken for granted that just because we have a strong voice, it's being respected elsewhere or everywhere. So, maybe answering your question, one of the recommendations in the guidelines is to have a family peer support worker in the emergency ward of the hospital. This is something, in fact, that I have learned about I would say, 7 years ago. In Ontario, there was at least, I hope that it still exists, a program where a family peer support worker was seconded to the hospital and by the community, and her role has been to attend to families who come with a loved one in crisis, and again to orient them, to provide them support, information, and so on and so forth. We have decided to model this program here, and we have done that in the past 5 years in one of the hospitals. And I can tell you that it has not been an easy journey. I can say today that after some trials and tribulations, I believe that we are on the right track, but it was not easy at all. I think that it means to have a family peer support worker in the emergency or in the hospital for that purpose means to me to marry two cultures which are quite different from each other. And we have been challenged in a very significant way. As I said, I think that we are on the right track right now. We have another hospital where, learning from our experiences in the first hospital, we have made some conditions that we wouldn't have started a project like that if these conditions have not been addressed. So I have to say that it's going quite much better, and I'm very hopeful that we will be able to replicate this experience in other hospitals. So this is just one example of one of the recommendations in the guidelines. This is a tough one because this requires not only accepting an outsider in the ER, but also there is a cost involved. And as I said, I think that it really calls for a change of perception. But there are other recommendations which are quite much less difficult. And today we have a committee that works again with a third hospital, trying to put together brochures and flyers and all kinds of information in different formats that will be available in the ER, will be available throughout the hospital, So when families come to the hospital, and again, it may be families who don't come to the psychiatry department, but to other places in the hospital, there will always be some information available if people may require it. So this is just maybe, two very different recommendations. One is much more comprehensive and more difficult to implement, but another which could be relatively easy if you work together, of course, with hospital people.
Great, thanks, Ella. And just a reminder to participants on the webinar, in the chat section, hopefully you'll have seen the links that came up to the guidelines, and hopefully that's a resource that you're interested in checking out. I'm kind of keeping my eye on time and realize that we're starting to get close to the end of the webinar. So I was wondering if I could pose a question that maybe I'll start with Ella, and then we'll move to Laurel and the Family Council. And that's what kind of recommendations or tips or suggestions would you offer to an organization or program that has decided they want to start engaging families more?
Well, I'm not quite sure what you mean by engaging families more. I think that associations like AMI Quebec or advisory councils have to be visible in the community. This is what we have been trying for our 40 years of existence. I think that it's very much a word of mouth. I think that it's very much relying on other community organizations and anyone else to spread the word. And I think that, again, it's trying to be visible, especially where families are going to find themselves. And this is why, we suggested that the ER could be a good place. So it's really not just one strategy. It's really trying to think of any creative ideas that would help you to be relevant to people when they need you. The problem with mental illness is that people very often are not very well informed unless they absolutely need this information. So, if you are making all kinds of information available to people who don't really have a vested interest, don't expect that they are going to retain it and remember it to when they would need it. So I think that you always have to be everywhere, anywhere, for the benefit of those who may need it at one time or another.
Great, thanks.
My turn, excuse me.
Yes, please.
Carol, one of the first ways that we engaged families after we set up the Family Council was through newspaper ads for the family education program, and people responded to the point where we had waiting lists, and then we were able to screen people and recognize that some people just needed support. And so we screened them and streamed them into support groups, and other people went to family education programs, and then the support group people went to the family education program, and we just moved a lot of people through. Not everyone stayed engaged, but everyone was helped as much as they needed at that point in time. So I always thought the big ad that went into the newspaper and was very public was something that brought people out. Don't you agree, Sandy?
Definitely. I mean, basically what we did was triage.
Yes.
And the ad caught their eye, and they called about that, and then we could talk with them on the phone about what their needs were and direct them. So publicizing the services is really important. Through doctors' offices is another way to make people aware of what programs are available. And if the programs are relevant to people and they're made aware of them, then they will access them. In terms of the council, I think something that's been really important is that the hospital has given us power. They have said, we will give you the money, we will give you the space, we will give you staff to consult with. Now tell us what you want to do. And as long as we were reasonable, which we always tried to be, they accepted our recommendations and they supported us in them. And they came to realize over a period of time that family members are competent people. and they came to respect us and thereby treat our ideas with respect. And so, you know, it went back and forth that we were working together as partners.
When we talked about setting up the provincial organization, there were 3 members of our own family council who started that, who initiated it. And we were supported by our corporate champion, Deb Coring. And when we began to go into Toronto to meet with people from the Clark Institute and Ontario Shores and Hamilton, they would pay our expenses. They didn't expect us to pay our own train fare or if we had to stay overnight. They were very, very supportive of us. And I would say that wasn't the case for all hospitals.
Great. Thanks very much. It's great having your collective wisdom online that we can all kind of tap into. We had another question come in, and that was, how does the Family Council, or does the Family Council connect with patient councils, and if so, how?
Oh, absolutely. Actually, we work very, very closely here with our patient council. As I mentioned in the section of collaboration and partnership, we partnered with the patient council here on numerous projects, and we will advocate and lend our voice together because collectively we have a lot stronger voice. And we also I am aware of the other councils throughout Ontario as well, because like us, the Patient Council also have a provincial body of Patient Council, and working in close proximity with the Patient Council, I do come into contact with other provincial bodies.
And we engage in projects with them upon their request, and we attend joint meetings if there is a topic of common interest. And actually, just historically, it's the person who was the paid staff for the Patient Council, which existed before the paid staff for the Family Council. It was through her efforts within the hospital that a lot of the resource center was set up. So she advocated very strongly for us initially.
Thanks. And then we've had a couple of questions come in, and that's how you've worked with or engaged with service providers. So one question is how long did it take to be respected by professionals?
A while. A while. Again, it's partly the evolution of understanding of mental illness that helps with that. But it's also just being there and getting to know the people and them getting to know us. Because quite honestly, at the beginning, there was a sense that if you had a family member with mental illness, you had mental illness. Or more than that, you were probably developmentally challenged. When they came to realize that hey, we have the same education, the same background, the same everything as the staff does, and that we're there to help and work with the staff, not to undermine them or work against them, then it totally changed. And, you know, I think it's that way with any, I have a background in education, and I remember going through the same thing when we started to get families more involved, and it was, oh my God, here comes a family member, you know, what do we do? And then after a while, you come to realize that you're partners and you're working for the same common goal, which is the well-being of the student or the patient. So it took, you know, I don't think it would take as long now as it did when I first became involved, fortunately. I think we're hearing from people who are new to the council that the information and access and partnership that they're getting is much, much better than when we originally got started in this whole process.
Mm-hmm. Thank you. Oh, go ahead.
I think initially family members quite often were upset and not knowing where to turn and feeling frustrated, and I don't think that stance sets up a good dialogue with a professional. And so if you can both come into the conversation calmly and speaking from the same playbook, you're further ahead. And so I think that it's worked because the professionals have learned how to speak to families just as families have learned how to speak to professionals. So we've all grown, and it's changed for everyone.
Thanks, and we're quickly starting to run out of time, so maybe I'll just kind of throw this question to Ella as possibly one of the final questions. So Ella, just from your experience, I'm wondering if you have any tips for service providers who are working with families.
Well, I think that it's exactly what we just said earlier. I think that you really have to be very determined. I think that you have to continue to work with the service providers. In all likelihood, service providers are not going to come to you. Again, it may be an exception that the Family Council in St. Joseph have such good relationship with the hospital. But, I wonder, when would be the time that the service providers will actually come to us here. It's very often we go to them. But I think that, I think that in order to, help them recognize the importance or the potential importance of families' contribution, I think that it's really our responsibility, the responsibility of family associations to initiate this contact and to just not to give up. I very much agree with what was said earlier, that this is really an evolving science. I think that, I'm thinking about 40 years ago when AMI Quebec started, like four families who got together because they were totally shunned by professionals. This is certainly not the case today, but still, I think that the initiative usually comes from family associations, and once service providers recognize that family associations have something to offer, and this is, I said earlier, beneficial for both parties, it will be much easier for them to accept families.
Great. Thanks very much. This has been a really great webinar, and we've been getting questions in fast and furious, and people have been really engaged. So I really appreciate the time that all of our presenters have taken to be here and to share some of our expertise. And we received quite a few comments from the audience thanking the family members for coming on the call and sharing your experiences.
Thank you very much for providing us with this opportunity and speaking about the successes and how our Family Council has grown throughout the years. So we appreciate the opportunity.
Yeah, it's been great to be able to hear both about, I think, probably some of the challenges you may have faced, but certainly being able to look at some examples of success and kind of having a sense of how you formed your committee and how it's making an impact. So just to start to wrap up, we wanted to bring your attention to another webinar series that is going to be launched in February. And this is about promising practices for caregiver engagement, and it's through the Evidence Exchange Network and their caregiver community of interest. So there's going to be a 3-part webinar series that's going to be looking at promising and established practices for family caregiver engagement. So they're looking at breaking the barriers, family navigation programs, family peer support, exploring 3 perspectives, and the pyramid of care from theory to practice. So the first one is February 28th at 12 o'clock Eastern Standard Time. And then just keeping in the vein of webinars, a reminder that we'll be continuing with the recovery-oriented practice webinars. And we typically hold them monthly, but we will not be holding one in March. And so our next recovery webinar will be on April 20th. And so stay tuned for more details, and we'll hope that you can join us for that session. And so finally, as you're closing out and leaving the webinar, we do ask that you take a moment to fill out our customer satisfaction survey, and that's going to pop up on your screen as you're leaving. And as we mentioned at the beginning, it's really important because it's a chance for us to get a sense of some future topics in areas that you might be interested in having seeing webinars on. And also it's really important because if you'd like to continue to receive invitations to our monthly webinar series, then for privacy reasons, we ask that you complete the survey and let us know that you would like to be contacted for future webinars and events. So thank you very much for joining us today, and then a big thank you to our presenters, to Ella, Laurel, and the members of the Family Advisory Council who joined us. It was really great to have your insights and experiences and for you to share that with us. A special thank you to Benita Varga and Laura Mullally, who are with me in the room today and are providing their assistance on answering some of your questions and kind of helping to keep things going. And if you have any questions about today's webinar, please contact us at the Mental Health Commission, and we look forward to connecting with you again in April.
Well done, everybody.
Oh, yeah.